Hi, I'm Dr. Leah Rurvig, a family doctor and geriatrician. I'm also a medical educator and I've taught clinicians working in prisons. I'm part of the AMEND team at the University of California at San Francisco. Welcome to this brief presentation, which was designed specifically for clinicians working in correctional facilities. I will discuss prognostication generally and then review its application to providing medical justification for early release in the setting of the COVID-19 pandemic. This presentation was created by physicians and experts in correctional health from AMEND, a program of the University of California at San Francisco. At the end of the presentation, I'll provide you with a website where you can find more information about our work on COVID-19, as well as an email address where you can send us any questions or comments you may have. I hope you find this presentation useful in your work. What are we going to talk about today? First, we're going to talk about the definition of prognostication. We'll talk about why prognosticate, how to prognosticate, prognosis unique to the setting of COVID-19. And then finally, we'll talk about using prognostic information to recommend early medical release, also called compassionate release. So what is prognostication? Prognostication is estimating the probability of an individual developing a particular outcome over a specific period of time. In other words, their prognosis. In general, as clinicians, the outcome of interest when discussing prognosis is mortality. So how long do we think someone's going to live? Generally, when we talk about prognosis, it means that the probability of death is more than 50%. In other words, the person is more likely than not to die within 6 months. So if you think there's a 51% chance rather than a 50% chance of death, the person has a prognosis of 6 months. Absolute certainty is not required for prognosis because, of course, absolute certainty in general is not possible. Why prognosticate? Well, we know that prognostic information changes decisions that patients make about their care. For example, in a landmark study from 1994, older adults were asked about their preferences for end-of-life care. Initially, when asked if they desired CPR in the case of cardiac arrest, 44% of patients said they would want CPR. But once they learned about the low probability of survival, really very low, the number desiring CPR dropped down to 22%. So a really big change in the preferences of these patients. Another reason to prognosticate is to assist patients in guiding their life planning. So for many patients, if they know that their prognosis is 6 months, 12 months, 24 months, they'll want to get their finances in order. They may wish to address relationships with certain friends or family. A third reason to prognosticate is to better your prevention efforts. So for example, you should not be prescribing statins for primary prevention if a patient's life expectancy is 2 to 5 years. You really want to target your prevention interventions to patients whose life expectancy exceeds the time to benefit. You also want to prognosticate in order to better target your screening efforts. So for example, colorectal cancer screening will not benefit a patient with a life expectancy of less than 10 years, but they could be harmed by a colonoscopy. So again, if someone's life expectancy is less than 10 years, you wouldn't want to offer something like colon cancer screening or mammography for breast cancer screening. The fifth reason to prognosticate, most clinicians are already familiar with, which is in order to determine a patient's eligibility for hospice. In order to be hospice eligible, you do need to have a prognosis of 6 months or less. And finally, and most relevant to this talk, is eligibility for early medical release, also called compassionate release. Now, states and jurisdictions around the world use many different terms for early medical release. They include compassionate release, which is the term I'll use, medical parole, geriatric parole, and in this presentation, we're using the term compassionate release to refer to any early release mechanism that's justified by increased medical risk in the setting of COVID-19. So how do we estimate prognosis? So we'll talk about 3 different ways that you can do so as a clinician. The first way is clinical judgment, and I tell providers never discount your clinical judgment about a patient's life expectancy. However, we do know that in general, physicians and nurse practitioners are too optimistic when it comes to estimating prognosis. In general, providers overestimate survival by a factor of 3 to 5. We tend to be most accurate as healthcare providers for very short-term prognosis, so a patient who's only anticipated to live for more hours or days, or a patient who has a long prognosis, like many years. However, we tend to not be very accurate in the middle distance of a patient who has weeks or months to live. Finally, we as healthcare providers are very influenced by relationships. We know that the length of a doctor patient relationship increases the odds of making an erroneous prediction about a patient's prognosis. In general, the longer you've known the patient, you tend to overestimate their prognosis. A second way to estimate a patient's prognosis is using life tables. And in general, what a life table shows you is that in a certain country's population, at a certain time, for a certain age of person, what is their anticipated life expectancy? For example, for a 68-year-old woman in 2007, her anticipated life expectancy is 17.5 years. But we know that life expectancy for people of similar ages is very varied. Most of us can think of an 80-year-old patient who's very healthy and an 80-year-old patient who's very frail, who has many chronic medical conditions, who has cognitive impairment. Of course, we don't think that the life expectancy for those two 80-year-olds is the same. This type of life table really shows that you have a different life expectancy depending on your general quartile of health. However, this, of course, again requires clinical judgment in order to determine which patients are in the bottom quartile, the middle quartile, or the top quartile. So another way we have to think about prognosis is to use prognostic indices. What is a prognostic index? A prognostic index is a clinical tool that combines contributions of the history, the physical exam, and lab findings towards a prognosis or likely response to treatment. Targeted prognostic aids exist to help with specific conditions. Most clinicians will already be familiar with the MELD score. It's the model for end-stage liver disease. And it includes the INR, the creatinine, whether a patient's on dialysis, their bilirubin, and their sodium. You plug that information into an online calculator and you get a pretty accurate estimate of their 3-month mortality. Fewer clinicians, in my experience, are familiar with the Seattle heart failure model, which is a prognostic index used specifically to prognosticate for patients with heart failure. You put in a lot of different information about the patient in this model: their gender, their heart failure class, their ejection fraction, their lab values, what medications they're on, and this will give you a sense of their mean life expectancy. And again, this is freely available to anybody at an online calculator. General prognostic calculators are also very useful tools. I really love to use ePrognosis. It's a repository of published geriatric prognostic indices. So in other words, what they have done are taken the results of a bunch of different prognostic studies and compiled all that information onto this one website. E-prognosis is really best for older adults who don't have a dominant terminal illness. So if you have a patient who's 75 and has some cognitive impairment and has some heart failure that's sending him to the hospital, this is a very great tool to think about the prognosis of a patient like that. This is not a very good tool for a patient, for example, who's 55 and has metastatic colon cancer. But even when you're using a prognostic index, prognostication is still an art. So what we really recommend is that you combine clinical judgment with a prognostic index to try to make it accurate a guess as you can. And remember, if you believe that the patient is more likely to die than to be alive within 6 months, then they have a 6-month prognosis of death. You are allowed to be wrong. 100% probability is not required in prognostication. So just to give an example, I'm a geriatrician, so I very frequently certify patients for hospice. However, sometimes my estimate about prognosis is wrong and a patient lives longer than 6 months. That's completely fine. That patient will then get recertified, presuming that they continue to get sick or get sicker, they will be recertified for another 6 months receiving hospice services. Let's talk about prognosis and the unique situation of COVID-19. Data from around the world show that age is the single strongest risk factor for hospitalization, ICU admission, and mortality from COVID-19. The chart on this page is COVID-19 data from the United States from the CDC. That's from the middle of February to the middle of March. The red circle highlights that for those patients who are 85 and older, the case fatality rate ranges from 10 to 27%, so very high. And for patients who are in their 70s to 80s, the case fatality rate is 4 to 10%, so also extremely high. This graph was by Dr. Wadera, and you can find it at his GeriPal blog. Data from China and Italy, also compiled by Dr. Wadera, also demonstrates a case fatality rate from 15 to 20% for those patients who are 80 or older. So we think that 15 to 20% is a pretty accurate estimate for these older adults. We also know that certain chronic conditions are associated with increased risk of severe COVID-19. Those conditions include cardiovascular disease, chronic lung disease, such as COPD and asthma, diabetes, and hypertension. However, there is a lot we still do not know. For example, we don't know exactly how much any of these chronic conditions increase the risk of severe COVID. We don't know how much risk is increased if you have multiple conditions. So if your patient has chronic lung disease and diabetes, what is their risk? We also don't know how functional impairment contributes to severe COVID-19. So in other words, if your patient has difficulty with their ADLs or IADLs, we're not sure how that interacts with their COVID-19 outcome. And finally, we don't know if having tight chronic disease control decreases the risk of severe COVID-19. So let's say your patient has diabetes under excellent control with an A1C of 7. We don't know if their risk of having severe COVID-19 or a really bad outcome is the same as someone with an A1C of 10. And again, I should have said before, when we talk about severe COVID-19, we're talking about COVID-19 that requires hospitalization, potentially ICU admission with potentially intubation as well. I do want to point out a large study of more than 72,000 COVID-19 cases in China. The overall case fatality rate in that large study was 2.3%. So just as a comparison, the case fatality rate for influenza is 0.1%, so much lower. This study found that the case fatality rate among patients with COVID-19 and cardiovascular disease was 10.5%. So in other words, those patients with cardiovascular disease and COVID-19 had more than 4 times the risk of death compared to those patients who had COVID-19 but did not have cardiovascular disease. The risk was also very elevated in diabetes, very elevated in chronic respiratory disease, hypertension, and cancer. So just to give you a little bit of a sense of the magnitude, although again, this data is somewhat preliminary. Let's talk about using prognostic information to recommend compassionate release and how exactly you can go about doing that. Healthcare professionals are the ones to determine a patient meets medical criteria for early medical or compassionate release. In the setting of COVID-19, prognostication must account for the fact that patients who might not normally be considered to have a prognosis of 6 months or less are now in that category due to the grave danger of death posed by contracting COVID-19. In other words, your patient who, let's say they're in their late 70s or early 80s, who may be quite healthy, maybe they just have hypertension, that person is at high risk of death were they to contract COVID-19. One thing that's important to consider is that if you don't end up having a COVID-19 outbreak in your facility, then your patient's prognosis, all of them, is exactly the same as it would have been pre-COVID. But once there's an outbreak that's about to happen or is going on in your institution, then the prognosis changes greatly. Of course, if there's actually an outbreak or early outbreak in your institution, we anticipate then the doctors are going to be too busy to take care of those patients to even think about prognostication. So that's why, to the extent it's possible, we really, really are encouraging providers to think about prognosis and COVID-19 before there is an outbreak in your facility. We have 2 specific recommendations in terms of compiling information to recommend compassionate or early medical release. The first recommendation is to make a checklist to communicate your recommendations about the patient. A checklist form will ensure that you assess and include the same information for every patient, and I'm going to show you a sample checklist letter on the next page. The next option is to develop a narrative letter format where you communicate in lay language complex information about a patient to deciding bodies. These types of letters are consuming to craft, and therefore it's usually best to create a narrative form letter that you can use, of course, with modification for multiple patients. Using this checklist or a narrative letter allows correctional healthcare staff to give medical evidence about prognosis in a very easy to understand format and to clearly describe your rationale for recommending compassionate release. So let's take a look at a checklist letter. First of all, very important to note, this checklist letter can be downloaded as a Word document on our website listed here, amend.us/COVID. Please download this template and modify it however you see fit. We have put this out there really for your use, however it needs to be modified for your institution and the type of patients you take care of. As you can see, this letter allows you to point out the patient's age, any major comorbidities that we know tend to worse outcome for COVID-19 infection, whether they've been hospitalized in the past year, whether they require any assistive devices or oxygen, their general healthcare utilization needs, the number of medical beds at your facility, the number of ICU beds in your community, and so on. If you're going to craft a narrative medical condition letter, it should have various components. You should start with a basic statement of the patient's main medical condition. You should include information about their degree of impairment and any other serious conditions they may have, information about the patient's functional ability, their symptoms and what's required to manage those symptoms, the intensity of services or nursing care that the patient may require, the likely trajectory of their illness, so whether they have chronic conditions or severe conditions like cancer that are getting worse, getting better, or that you anticipate will stay the same over the next 6 months to year. And then in terms of prognosis, you want to include objective prognostic evidence and prognostic evidence unique to the setting of COVID-19 outbreak. You want to give recommendations regarding the standard of care and include a discharge option if one is known. Let's go through this sample narrative letter. This is going to be time consuming to read through. It'll be the next 3 slides, but I think it's really worth it to see what we're talking about in terms of these narrative letters. Mr. A is a 74-year-old man with severely reduced heart function resulting from multiple heart attacks in the past. His heart is extremely weak and he uses oxygen. He also has diabetes. He has been hospitalized 3 times in the past 6 months for heart failure. He spends most of his time in bed or in a wheelchair due to shortness of breath and fatigue, and he uses a walker. He is short of breath even when at rest. So you can see here we're giving the age. His major medical conditions are described in lay language. His symptoms are described, and his function is described, as well as some information about his recent healthcare utilization. Mr. A's overall medical vulnerability and his medical conditions mean he is at very high risk of critical care need and death if he contracts COVID-19. Age is the most powerful risk factor for ICU placement and death in COVID-19. Mr. A is in the second highest risk group for age. There is currently a COVID-19 outbreak in our facility, county, or city. Studies have shown that cardiac disease alone carries a significantly increased risk of death or ICU admission from COVID-19. We estimate Mr. A's risk to be particularly elevated given he also has diabetes and his heart failure is very advanced. So here you see we're pointing out certain significant risk factors he has here for COVID-19, as well as information that's unique to your facility, your county, or your city, if you happen to live in a state or jurisdiction where there already is a large COVID-19 outbreak in the community. Of note, our facility has 4 medical beds, all of which are currently occupied. The community hospital in our county has only 4 ICU beds, and cases of COVID-19 have been identified in our surrounding communities. Mr. A poses a high risk of requiring a medical bed or transfer to outside medical care, even if he does not contract COVID-19. According to the Seattle heart failure model, Mr. A's life expectancy is about 3 years, although I estimate that his prognosis may be shorter given his current need for assistance with basic activities like showering. So here you see they're pulling in information about medical resources available at your institution, and then also including prognostic information in light of Mr. A's heart failure using the Seattle heart failure model. In his current stable status, Mr. A requires a weekly clinic appointment, close monitoring of his weight, frequent adjustment of medications, and twice monthly labs. Managing Mr. A's health requires significant medical resources from the correctional and community healthcare staff. These critical resources could be reallocated to a possible surge in COVID-19 cases upon Mr. A's release from custody. For these reasons, the healthcare team strongly recommends immediate release pending an appropriate housing and medical discharge plan. So this is just, again, summing up further detailed information about his healthcare utilization and how these Resources could be redistributed were the patient to be released. In sum, you already have access to accurate prognostication tools for common conditions like heart failure and end-stage liver disease. This information can help you craft a basic form letter, whether it's checklist or narrative, for compassionate release, which can be filled in with specific information for individual patients. Furthermore, COVID-19 specific prognostic information should also be incorporated where possible in these letters. So, of course, that will be very impactful for anyone who has any of these common comorbidities or any patients who are older adults. Please access our sample letters and our templates at our website and adapt them to meet your needs. Again, we're Amend at UCSF. We're a health-focused correctional culture change program led by experts in medicine, public health, and correctional health and policy. We work with correctional departments to promote the health and well-being of people who live and work in U.S. jails and prisons. These slides were prepared by myself, Dr. Williams, the director of Amend at UCSF, with assistance from Dr. Wadera. Thank you so much for your service. Please stay safe. I know this was a lot of information. If you have any additional questions, or if there's a topic or question you want us to address in a future video, please email our program manager, Kevin Reeder, at kevin.reeder@ucsf.edu. Thank you so much for your attention.